Pain between the shoulder blades is treated as a muscle problem by default. Sometimes it is a joint. The costotransverse joints, the small synovial joints, where the ribs meet the transverse processes of the thoracic vertebrae, have been described as potentially prevalent but overlooked pain generators in the thoracic spine. Mid-back pain gets less attention than low back pain or neck pain, and it is harder to pin down. The source of thoracic back pain is often challenging to diagnose and manage because multiple potential causes and treatment strategies exist. One consequence of that is predictable. When no single cause dominates the picture, the pain gets managed as muscular by default, even when a specific joint may be the structure generating it. So let me spend a minute on a structure that is easy to miss. The costotransverse joints are small synovial joints. Each one is the place where a rib meets the transverse process of a thoracic vertebra. They are worth knowing about for two plain reasons. They sit exactly where people point when they describe pain between the shoulder blades. And nothing about the symptom itself announces a joint rather than a muscle. It simply hurts in the middle of the back. Here's what a fully worked up case looks like. I want to be precise about what this is before I describe it. It is a published case report. One patient, not a trial. The report describes a 35-year-old woman with thoracic hypomobility. The report describes a 35-year-old woman with thoracic hypomobility. She had a severe pressure sensation and a dull pain in the T7 to T10 region on both sides, between the medial borders of the shoulder blades. Physical therapy did not help. Pain medications did not help. A thoracic epidural steroid injection did not help either. CT imaging of the thoracic spine then revealed isolated arthropathy of the costotransverse joints at T8 and T9 on both sides. The sequence that followed is the actual lesson. First, an intra-articular steroid injection, which gave significant short-term relief. Then a diagnostic block, which produced over 80% pain relief. That block is not the treatment, it is the confirmation step. It is how you establish that the structure being blamed is the structure producing the pain, before anything longer lasting is attempted. Only after that came thermal radiofrequency ablation of the nerves to the costotransverse joints at T8 and T9. The patient had 3 months of relief with functional improvement and reduced pain medication requirements. Now the caution, and I mean this one, treat that as an illustration of method, not as evidence of how well the procedure works in general. One patient cannot establish efficacy. The authors themselves note the need for further anatomic studies, describing the complete innervation of the costotransverse joints. This is an area still being worked out. What the case does show is a logic worth holding on to. Identify a candidate structure, confirm it with a block, then treat what was confirmed. That same sequence is described for facet joint pain and medial branch blocks. There is a second thing worth saying, which is that thoracic pain is not only an older person's problem. A cross-sectional study looked at 1,628 Brazilian high school students, aged 14 to 18. In that group, the prevalence of thoracic spine pain was 51.5%, about half of those students. That population is adolescents, not adults, and the figure should not be transferred to adults. But it does indicate that the problem starts early. In that same cohort, thoracic pain was associated with female sex, with using a computer more than 3 hours a day, with using a cell phone in a semi-lying position, with using a cell phone more than 3 hours a day, and with the presence of mental health problems. Regular physical activity was a protective factor. Again, those findings come from 14 to 18-year-olds and should not be assumed to apply unchanged to adults. So where does evaluation actually go? Because several structures can generate mid-back pain, the useful question is which one established rather than assumed. Depending on the history and the examination, the relevant options include facet joint injection, facet joint radiofrequency ablation, and trigger point injections where muscular referral is contributing. Digital X-ray and image-guided procedures using ultrasound or fluoroscopy are what make the diagnostic steps precise rather than approximate. Where a vertebral compression fracture is a possibility, kyphoplasty and vertebroplasty are the relevant procedures. And there is one category that does not wait. New thoracic pain accompanied by unexplained weight loss, by fever, by a history of cancer, or by any neurological change should be assessed promptly rather than managed as mechanical pain. If pain between your shoulder blades has been treated as a muscle for months and it has not moved, the question worth raising is not which muscle, it is which structure and how would we confirm it. The question worth raising is not which muscle, it is which structure and how would we confirm it. To have mid-back pain evaluated, request an appointment at painmd.tv/appointment. Call 314-481-5000 or text 314-886-5902. We have two locations, 4477 Woodson Road, Suite 100 in Street Louis, and 12174 Natural Bridge Road in Bridgeton. You do not need a referral, and you do not need to be an existing patient.